I'm just going to give a 40,000-foot view of early detection, kind of where, what we've done over the last number of years, where the bottlenecks have been, and at least make a proposal of perhaps how we can go forward in a more thoughtful, organized way. And you know, Anirban mentioned at the beginning, there's been a compelling set of data that have been generated by the PanCan group, and that's listed on the bottom, that if you just look at trends in different cancers, if we don't change the impact that we've had on pancreatic cancer, at least data generated in the state suggests that by 2030, pancreatic cancer will become the second leading cause of cancer death in the United States, which is a pretty sobering number. And if you look at how we can try to approach and making an improvement on that, there's really three ways to go about it. And the normal order by which we should be addressing this probably is the reverse of what I have listed here, which is we should really be going after prevention, probably second, early detection, and then third, more effective therapies. But I've listed these areas in the reverse order because I think this is the order we put our efforts in, which is we put a lot of time and effort into trying to develop therapeutics, and less so on early detection, and actually not very much effort at all on prevention. And I think we need to try to have a more balanced approach in trying to tackle this disease. When we think about early detection, you know, pancreatic cancer is really tough, and I think unique among other cancers. In this data slide, which Matt Firpo was nice enough to send me yesterday, kind of highlights what's unique about pancreatic cancer, which is even with stage 1A disease, the survival rate is 31%. I mean, that's not true of any other cancer that I know of. There's something very unique about pancreatic cancer that promotes it to metastasize very early. And so when we think about early detection, we can't be thinking about stage 1 disease. We really have to have our target lesions be PANN3 lesions. And then for cystic tumors, which we're increasingly seeing a lot of, high-grade dysplasia in the mucin-producing cystic tumors, IPMNs and MCNs that we know can go on and form cancer. So just to summarize on one slide, and not to do disservice to all the investigators, many of whom are here in the room that have done a lot of work trying to identify biomarkers in pancreatic cancer, you know, this has been a difficult go. I'm going to talk a little bit about why, but just to briefly summarize, you know, we've had a lot of work done on biomarkers. We've gone about trying to tackle it by looking at protein biomarkers, either individual biomarkers alone or in combination with CA19-9, sometimes using small panels. There's been work looking at microRNAs, changes in methylation, autoantibodies, exome circulating DNA. Lots of different biosamples have been used. I think we all think that probably the best path forward is going to be having a blood test, but certainly biomarker studies have been done in other body fluids, and we'll hear about saliva on the following talk. Duodenal aspirate, stool, saliva, and pancreatic cyst fluid. But, you know, the sobering information is, despite all this work, all very well intentioned, we have not, as of yet, come up with a clinically usable biomarker to detect pancreatic cancer at an early stage. So why is that? Because this is a really tough problem. The incidence of pancreatic cancer is relatively low, and so you have to, there are lots of issues with trying to get at a good biomarker. There aren't as many people that have been working in the field. Almost all the patients we see in clinic have late-stage disease, so a lot of this discovery work in identifying biomarkers has been done with late-stage samples. We don't know if those findings are going to be relevant for early-stage disease. Many studies lack proper disease controls. There are many a biomarker that have looked very promising when you're comparing advanced cancer to normal, but then when you do the controls that need to be done, like chronic pancreatitis, diabetes, biliary obstruction, the biomarkers fall down. And so while we've done a lot of legwork and discovery, the hard part is the validation. And the important message I want to get across is this is actually going to require cooperation across institutions, and we could probably do a lot better job at that. There's a nice review of the issue of sensitivity and specificity in Matt Firpo's paper he had recently in Annals of Surgery, but the numbers are pretty staggering. If you want to have an effective biomarker for pancreatic cancer, the sensitivity and specificity need to be almost 100%. For it to be cost effective to apply to the population at risk. And then I think it's also important to point out, and I've sat on a lot of these grant committees, for people who submit grants trying to do this work, if they're reviewed by people who don't really understand the nuances of pancreatic cancer, then the grants often don't get scored very well. The comments that I see people get is, well, just test this in stage 1 tumors, 100 samples. Well, those kind of cohorts don't readily exist anywhere. And so, this has been an additive effect to this problem. The other issue I want to bring up is, so if we're thinking about developing biomarkers, who should get screened? I list here who we consider to be higher risk individuals. People over 55, those with a family history of pancreatic cancer, some of whom we've identified genetic risk factors, and I list some of those here. Smokers, long-standing type 2 diabetics, people who are obese that are at higher risk. We know that people with cystic tumors and chronic pancreatitis are at higher risk as well. So far, the only screening programs that we have are in people who have a familial risk of pancreatic cancer or in some of these kindreds that have genetic syndromes. And if you look at this list of people who are at higher risk, there's not really a consensus of which population should be screened should we develop an effective biomarker. I just want to mention that I think there is some important work being done in molecular imaging for early diagnosis. Probably the most advanced work is that's been done by Kim Kelly looking at plectin. And I show a picture here of a mouse where she has an imaging agent where she can identify Panin-3 lesions using plectin. And she has shown this also in human tumors, that plectin is upregulated specifically at the Panin-3 stage. I congratulate Kim because she's developed an imaging agent, is actually doing a first-in-human study to try to identify Panin-3s, and the study is using this imaging agent I have listed here. And speaking to her yesterday, the study design is that the agent will be injected, there'll be multiple imaging studies done over time, and then surgical resection of a resectable pancreatic tumor 24 hours later, where there'll be evaluation of plectin imaging agent uptake into the pancreatic cancer itself and to Panin-3 lesions. So I think this is a promising area that we'll be keeping our eyes on. So not to be all doom and gloom, I think there's some recent bits of information and also some new technologic advances that may make a more favorable situation to try to develop biomarkers. There's been some recent papers that suggest that actually tumor cells circulate in the bloodstream much earlier than we previously were aware of. I'll just bring to your attention these two papers. One was actually published in Cancer Cell in 2008 that showed that cancer cells in women who have breast cancer in situ, which is thought to be a non-invasive disease, actually are found in the blood and the bone marrow. And importantly, there was a paper that was published by Andy Rim last year that also gave us insight into this phenomenon where he did lineage tracing in KPC mice and found that during the Panin stage that there were pancreas epithelial cells that were circulating in the blood and lodging in the liver. And I will tell you that Andy has subsequent data that isn't published yet, but that will be hopefully published pretty soon, showing that in Sendai-negative pancreatic cyst patients, that those patients have circulating tumor cells. So this suggests that there might be an opportunity to actually detect pancreatic circulating epithelial cells at the very earliest stages of tumorigenesis, even before invasive cancer is present. We've had a lot of technologic advances over the last several years in identifying circulating tumor cells. The only FDA-approved platform currently is called Cell Search, but it's not been found to be very helpful in pancreatic cancer. Really, the state-of-the-art is using these microfluidic platforms with the little chips. And I just want to bring to your attention what I think is a landmark paper that was published using this technology by Sunitha Nagrath, who was at MGH and happens to be at University of Michigan currently, where she was able to develop these EpCAM posts and obtain CTCs across a broad range of cancers. However, we do know that a lot of circulating tumor cells in pancreatic cancer are mesenchymal, and so using an EpCAM antibody may not allow us to capture many of the circulating tumor cells. And so it's important to know that there are a number of next generation microfluidic chips that are out there, not published yet, but that are in the pipeline that have antigen-independent separation techniques to allow us to separate out cancer cells from the blood. And so I think we want to keep our eyes tuned for these platforms because I think they're going to be critical for us to be able to isolate CTCs from patients going forward. And then also in parallel, there are lots of advances in platforms to do genomics on single or small numbers of cells. So the advancement of technologies in these two areas is going to be important. And I just show this slide from a recent review on CTCs. CTCs have a lot of talk about using them to try to predict therapeutics and also to determine mechanisms of resistance. But I think with advancement in some of the techniques that we will also be able to use them for looking at mutations and genomic analysis in early stage cancer. In parallel to the CTC field, there are a lot of advances happening in measuring circulating DNA, digital PCR, as well as next generation sequencing. I think the biggest advances have been made in digital PCR. I just want to bring to your attention this paper that was recently published because I think this kind of technology has implications for pancreatic cancer. We're using a digital PCR technology where you're able to compartmentalize and amplify single DNA molecules from picoliter drops. And this type of technology is currently available in the clinic. So in putting things together, what's really, at least my thought about what our path forward is for pancreatic cancer biomarker research, I think we should do a better job of standardization of collection procedures and collaborative sharing of biosamples with clinical data. As a result of the Pancreatic Cancer Recalcitrant Act that was passed by Congress, there was a number of us that met with Harold Varmus, and there really was not very much discussion about biomarker development and early detection. I think we need to have a stronger emphasis on that. I think it's important for people to realize there are already large biorepositories that probably have many of the samples that you need, including a lot of those control samples. And those biorepositories exist at large centers within spores, and so you should contact those of us who have spores in these biorepositories to try to help you if you're doing work in this field. I would like us to encourage inviting more engineers and chemists to our meetings. I think we underplay the need for interdisciplinary research in advancing our field. And I was just talking to Gabriella. I was glad she was here. But I think we should try to encourage that. And it's important that as these technologies go forward, that clinicians are thoroughly engaged and try to best understand how to integrate these technologies into clinical care. And of course, the last point is critical to all of us, is we need to work together to try to increase awareness and funding for promising areas of research and pancreatic cancer biomarker research. So with that, I'll be happy to answer any questions.